It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. A few announcements. We have an ultrasound course May 17th in New York, and I'm going to release some more dates possibly for the summer. Great conferences coming up. Aspen, NICIP, Latin American Pain Society, Pain Week. Be sure to register. I hope to be at all of them. And I was recently lecturing to a group in Indonesia, Trigeminal Academy, and I was talking about PRP and regenerative medicine and the evidence, and there were some leftover questions. So this is, I figured you'd all benefit from me taking a crack at these questions on the podcast as opposed to just answering this select few. So this is the first question that they wanted to know was if I had experience with PRP and a scaffold like hyaluronic acid or PRP with fibrin for tendon tears in the same time or different time. Well, the only scaffold or other substance I really inject in conjunction with PRP is hyaluronic acid. I don't typically do it on the same day. I know some people do. Bottom line is there's evidence that when you look at the shoulder and the hip, there are studies supporting that the combination of hyaluronic acid and PRP is superior to either one alone. That being said, this stuff is not yet well standardized, so keep digging into the data. I will, and I'll keep you guys updated. I do change my tune every now and then if I find a new study. And for instance, that goes for the local anesthetic when it comes to platelet-rich plasma. There's a 2014 study that I was citing that said that you should not mix any local with it, and then a more recent publication in 2022 stating that certain local anesthetics are acceptable and do not interfere with platelet function. So, and that stuff I delve into more in my lectures and my courses. Okay, they want to know about the RPMs and the spin technique. Every kit is different. I use a couple different kits in my time. One kit is 3,800 rotations per minute, and they spin it out for 2 and 5 minutes, whereas the current kit I'm using is 4,400 rotations per minute, and that's 2 and a 4 minute spin. Another question is, how about the dose PRP for each target like the knee, hip, carpal tunnel? There's no standardized dose for PRP, and in fact volume is one thing, and then the actual concentration can only be measured with a cell counter, and most clinics do not do that. My advice is, just get the best kit that you can find, and at the end of the day, the concentration of the PRP is really variable. It's what you make it when you mix it up, and the only way you know for sure is to actually look at the cytology, or the cytometry, I should say, the counting of the cells. In terms of volume, the knee could be 2 or 3 mLs, but a lot of it's relative. It's really what's the concentration of the PRP. So there's not a lot of standardization with this stuff yet. Until we all get cell counters in our office, it may vary tremendously. How do I manage severe pain, edema in the patient after a PRP injection? There are reports of pain for up to 2 weeks that can make the procedure want to refuse doing a PRP. Yes, that's true. Patients will get an exacerbation, usually a day or two, but from personal experience, I've had exacerbations for 2 weeks after a PRP shot, and I've had multiple PRP shots. So yes, this does happen, and really, it's one of those things where I guess the standard of care thing is tell people take Tylenol. However, there is a study saying Tylenol interferes with platelets, and another study, and I have the reference in my course, and drugs like Celebrex do not. So Go figure. I mean, that being said, I've been telling people Tylenol for years, and I feel like I've had pretty good outcomes with my PRP. Could they be better if I say avoid Tylenol? Possibly. A lot of these studies are done in a petri dish, so they're not in vivo. So you have to take it with a grain of salt. And once again, I think there'll be new studies coming out that really will shed some light on what's the best practice. Because most practitioners I know are advising patients to continue Tylenol, avoid NSAIDs, whereas, like I said, there is a study that I can quote saying that Tylenol does interfere with platelets, whereas meloxicam doesn't. So, go figure. How does the success of PRP depend on its quality? Yes, of course, I'm sure it does. In terms of the studies to support that statement, I have to dig deep about it, but I went to ASIP. Oh, by the way, ASIP's meeting's coming up. ASIP had some Toby lecturers, and they were mentioning that the concentration of PRP can be related to more relevant in older patients, and that might be related to the upregulation of growth factor receptors. So the older patients who don't see as many growth factors will be more sensitive than the younger patients to the concentration. What about mixing PRP with hyaluronic acid? Well, we just discussed that. Is low-quality PRP still better or superior than steroid injection? That's a great question. For low-quality PRP versus steroid, I don't know. I know general high-quality PRP versus steroid, the general consensus is for most cases, it takes longer to work but lasts longer. That I'm seeing, I'd say almost across the board. That is a very consistent thing through multiple different body parts, multiple different studies. Are there studies that go against that? Of course there are. Every study should be taken, positive and negative, should be taken with a grain of salt. So I hope that clarifies the questions you had for the platelet-rich plasma. Now I have to address another issue, which I am... Hopefully you guys see me as a pretty honest and transparent person. I published a video in which I did a brachial plexus selective nerve root block, actually, for the webinar I shot with Clarice. It's on my YouTube channel, and I demonstrated how to do the shot, the injection with the patient sitting. And there were some comments on the YouTube as to the vagal risk and that we should be lying the patients down. And I get that and I understand that. And of course, you don't want to put your patients at risk of any complications. And first of all, I've done probably more than any one of these, at least in the States. And I do this all the time because it's safer than an epidural steroid injection because if you're not near the spinal cord. Given it's safer if you can visualize your needle and identify blood vessels under ultrasound, right? If you don't know what you're doing, it's not safer. You could get into an artery, a vertebral artery. It could cause major problems. But the big comment that kind of is weighing on my mind is, doc, you're sitting the patient up. Aren't you worried about vagal? Are you doing something inconsistent with healthcare standards? So I learned pretty early in my career that the word standard of care, which is defined as level of skill, knowledge, and care that a reasonably prudent healthcare professional would provide in a similar situation. And this is considered a legal and ethical benchmark used to evaluate the quality of medical treatment and determine whether a healthcare provider has been negligent. Well, unfortunately, standard of care is sometimes poor care. And we saw this back in the early 2000s, the 90s, when everybody was getting opiates, and that was standard of care. Oh, your pain is not adequately treated? Take more opiates. Standard of care. So standard of care is kind of a weird term. I like the term best care, because best care is what a physician would do for his family member, for himself. So when I look at what I'm doing for my patients, and I look at the particular problem of cervical radiculopathy, and I'm seeing 90% of patients responding to a cervical selective nerve root block outside the spine, and the 10% that don't respond, well, we either send them to an epidural. If that doesn't work, you go to a surgeon. I think that is best care. It's still not standard of care. Standard of care is to give a cervical epidural for people who fail conservative therapy. And the reason for that is, well, lack of knowledge of ultrasound-guided selective nerve root blocks. The other reason is the reimbursement does not pay you for a ultrasound-guided selective nerve root block, but they do pay you for an ultrasound-guided brachial plexus block, and the brachial plexus does have nerve roots. So when I'm sitting a patient up and I'm demonstrating an injection or doing the injection, I do think there is a risk of vagal. And of course, if the patient passes out, hits their head, I am, I guess, responsible for that. One can argue that sitting the patient up is an easier way to identify the nerves and get access to them, and that will actually increase the safety of the procedure. I'm coming from a posterior angle where it's very hard to get into a blood vessel because I'm aiming from posterior to anterior, and I have the articular pillar to my medial side, which is kind of blocking me from getting into the foramen as well as getting into any blood vessel. So, like vertebral artery or feeding artery. As far as the carotid, that's way anterior, and that should be nowhere near where I'm aiming. So, and the vagal, have I seen vagals with this nerve root block? Sure, not many, but when it happens, first I'm always talking to the patient. If they don't feel right, just lie down. Stop the procedure, lie down. I have monitors. I have any resuscitative meds there. So I don't think I'm breaking with any healthcare standards. That being said, that even though most practitioners would not sit the patient up for this. Now, how did I go from being an anesthesiologist with patient supine doing brachial plexus blocks for OR cases to being a pain doctor doing almost higher brachial plexus blocks, like selective nerve root blocks, with a patient sitting up? And I actually didn't really think very hard about this. It just evolved. And what happened was I do shoulder shots, injections of the joint with them sitting up. And I think if you use an ultrasound, 90% of you do that as well. That's really what I see most practitioners do. I'm sure some of you do lie the patient down, but injections of the shoulder, typically the patients will be sitting up. The suprascapular nerve block, which I started doing probably 15 years ago, a lot of, because I had a period where there was no C-arm in my practice and I had to treat shoulder pain and cervical ridic, patients were sitting up. And then I realized that not every patient responded to the suprascapular nerve block and they needed epidurals. But before I did an epidural, what if I could just put a little bit of local and steroid, or now PRP, outside the foramen on the exiting nerve root? Well, that meant I just moved the probe a little closer to their neck. And it wasn't like I just went straight to doing these shots. I was doing first suprascapular, then maybe a little supraclavicular, then closer to the interscalene for the C5, 6, 7 nerves. And I saw almost every time the patients responded positively and didn't need an epidural. And then eventually, I don't know, maybe 10 years ago, maybe a little more, I put the needle, I traced the nerve root to the foramen, and I put the needle outside the foramen. And with 1 or 2 mLs of local, I'm treating cervical radiculopathy quite effectively. And it was easier for me, at least, to do it sitting up. So after doing really over 1,000 of these and not having one bad outcome, not one, and in terms of vagal, it's really a handful, very few actually. But the vagal, I don't feel right. Okay, lie down, check the pulses via blood pressure. It'll pass, it passes. So I'm not telling you to sit the patients up for these shots. I'm just explaining why I do it and how I handle it. Your comments on my video make me second guess myself in terms of, am I doing right by my patients? And at the moment, I do feel like I have better. I have tried doing this lying the patients down. You could do it either way, as long as you are able to recognize the vagal if it happens and make sure that the patient does not get injured. So it's like putting a patient to sleep. You paralyze them. But as an anesthesiologist, we paralyze them, but we do it in a controlled fashion. We know what to do if things go south, right? If you can't get the airway, the difficult airway algorithm, the steps that you take to make sure that you can ventilate the patient. So it's a similar thing with this. If the patient starts to not, you talk to them the whole time, you make sure that they are with you and not feeling lightheaded or dizzy. The second that something doesn't feel right, that they pause, you lie them down. And in fact, the fact that they're sitting up, they will have a quicker symptom. They'll be symptomatic quicker because of the nature of gravity that they're sitting up than if they were lying down. So you might know about the vagal situation earlier if they're sitting up. Of course, the main risk is really them falling and hitting their head. But they're sitting anyway. They're not standing up, right? They're sitting, and I'm prepared to lie them down with all the... So at the end of the day, do what you think is right. I'm not telling you what to do. But whatever you do, be prepared to handle whatever consequence may occur as a result of your action. So be prepared for that vagal. Be prepared if, God forbid, you have a vascular injection, which should not happen. Always throw Doppler on when you're about to inject the cervical nerve root, because those nerve roots can look like blood vessels. There is a higher fluid content, which one study a colleague passed on to me stated there is some CSF in those nerve roots, which kind of makes sense, right? That's why they're blacker. That's why maybe there's some transport of the CSF that can make this peripheral treatment for a central disc herniation effective. So on that note, I really hope that you guys understand that I do think and believe, and hopefully I am acting in my patient's best behalf when I sit them up for these shots. I probably don't need to give you an explanation to why I practice, but I really feel like I do, based on the comments on that YouTube video that I posted. And I hope you guys learn from this. And the key point is, take everything the books, the journals say, as well as your preceptors. However, at the end of the day, it's you and the patient. And you need to do what you think is best and safest. And sometimes the term standard of care is not best care. Sometimes it is. It's, an individual thing. So anyway, hope to see you guys at the upcoming courses, conferences. And remember, board prep season is starting. So if you need to prepare for the pain, anesthesia, or PM&R boards, go to nrappain.org or painexam.com, and you can register for either a yearly, monthly membership, get CMEs, or the virtual pain fellowship, which is kicking it up a notch and getting access to the ultrasound and regenerative medicine courses online. Thank you. Please share the podcast, and have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.